My name is Emily and this is Jardin. We are the co-chairs of Students Passionate About Mental Health for 2013. We would like to begin the night by acknowledging that UWA is situated on Noongar land and that the Noongar people will remain the spiritual and cultural custodians of this land. A few housekeeping comments to begin with. We'd appreciate it if you could silence your mobile phones. Toilets are located through the door at the front on the left, just through there. And emergency exits, there are 2 doors at the front and 1 at the back, in case anything untoward happens. The format for this evening will include pre-submitted questions in the first half, and intermission will be held at approximately 7:45 p.m. with light refreshments served in the foyer behind me. The second half of the evening is dedicated to audience members, where you're encouraged to ask questions to the panel.
So a little bit about Students Passionate About Mental Health. We're known to most people as SPAMH. We were born in July 2011 as a product of several passionate medical students. We're run at UWA and we're the mental health subcommittee of the Western Australian Medical Student Society. Annually, we run several different events throughout the year. We have Coffee Club, which is designed for students, and these are intimate discussions held over a cup of coffee facilitated by a guest speaker in a specialty field. Past topics have included studying and mental well-being, motherhood and mental illness, and caring for carers. We also run an awareness event to promote Are You OK Day each year at UWA. Are You OK Day is a national initiative which encourages open lines of communication between family, friends, and colleagues. And our signature event is our Q&A panel, which is this year entitled Down and Out. Wealth, status, power. They say money can't buy you happiness, but can it buy you better mental health? Tonight we look at the relationship between socioeconomic status and mental well-being, if there is one, and the factors which influence it and the outcomes which result. In particular, we'll be exploring more about often marginalised groups in our society. For example, youth, Aboriginal and Torres Strait Islander peoples, the homeless, the incarcerated, refugees and asylum seekers, just to name a few. We hope you enjoy what will be stimulating discussion. I'll now hand over to Jade, a member of our SPAMH committee, and she'll introduce our facilitator and panellists for tonight.
Good evening, my name is Jade. I am the 2013 Secretary for Students Passionate About Mental Health, and I'm very honoured to introduce our esteemed panel this evening. Firstly, I'd like you to introduce you to our facilitator, Isaac Lim. Isaac is a final year medical student and one of the founders of Students Passionate About Mental Health. He has many achievements behind him, both through Students Passionate About Mental Health and through his medical studies. So we're very honoured to have him as our facilitator this evening. In our panel, we'll start on the right-hand side. We have Annabeth Bateman, who is from Headspace. Annabeth has a lot to do with youth affairs and mental health and has been seen at many different youth events in WA and at the opening of the Fremantle Headspace Centre. So I'm sure she has some interesting opinions to offer us about youth mental health and also rural mental health, since she's originally from Albany. Next we have Dr. Marshall Watson, who is a Noongar man and a registrar for a juvenile forensic psychiatrist, to have it correctly. Marshall has some very interesting things on the topic as well. Next along we have another forensic psychiatrist in Dr. Sophie Davison. She's published some fantastic papers on the subject of women's mental health and incarceration and also on migrant and refugee mental health. Next along we have the esteemed Dr. Carmen Lawrence. Many of you might know her from teaching third year sexual health classes back in the day for UWA medical students, or as the first female from UWA, but this evening she's here to give us a bit of perspective on mental health. Next along we have Linda Morrison from St Bartholomew's Homeless Shelter. Linda's the mental health manager there and knows a little bit about the more political side of the program. And finally I'd like to introduce Dr. Nathan Gibson, who's the current chief psychiatrist at WA, and I'm sure he'll have many interesting opinions. I'd like to pass over to Isaac now for the rest of the evening.
Let's crack on and get into some questions. We have a mental health commission in Australia, and one of our commissioners is Professor Ian Hickey in Sydney, and he said earlier this year that affordability remains one of the biggest barriers to effective care. And he said that there remains a large out-of-pocket expense for people living with mental illness to access GPs, psychologists and psychiatrists. And he concluded, and I quote, "There are much better services for better off people." Professor Carmen Lawrence, you've written extensively on the subject of inequality in Australia, and I'd like to know, how can we address this disparity in access to mental health services, particularly when we're told that we're in the midst of a national budget crisis?
Well, I guess I'd take a step back from that and just very quickly say that one of the important things not to lose sight of is that there are big socioeconomic differences in the incidence of all sorts of illnesses, including mental illness, and the genesis of that is the subject of wide investigation. So people from low socioeconomic status start behind the eight ball. Societies that are very unequal also produce high rates of mental illness, and our society is tipping in that direction as well. And of course, one of the signs of inequality is the distribution of resources for the purchase of services. So that the public health system typically is under-resourced, the private health system has more resources than it needs when you're talking about doctors or money. So we do have a serious problem in the misallocation of resources. It's not what we need.
Dr. Sophie Davison, you're a psychiatrist. What, in your view, is this relationship that Carmen Lawrence is referring to between socioeconomic status, as it were, and mental health?
A complicated one, I think, is the easy answer. And I suppose I'm aware that in the field in which I practice in forensic psychiatry, dealing with people who are at the intersection of the criminal justice system and who have mental health problems, my perspective comes very much from dealing almost exclusively with people from the lower socioeconomic groups, because they're doubly disadvantaged and doubly stigmatised, the groups that I work with. I think you probably need to ask a public health psychiatrist more about what the actual relationship is. I think there's definitely, if terrible things happen to you in life, you lose your livelihood, then you become poor, then you under stress, that's a risk factor for mental illness. There's also the fact that there's very good evidence that poverty has a really serious effect on the mental health of children, so that they start off with developmental problems and then that places them at risk of becoming adults with mental health problems, and so the cycle continues.
And you yourself work in the public mental health system.
Yes.
Do you feel the strain of under-resourcedness?
As a public employee, I must. I think that everybody feels that strain. There's a huge amount of need, and once you start working with prisoners, they're not actually eligible for Medicare if you're in prison, and so they are dependent on what resources are made available for health in prisons as well. And that depends very much on the jurisdiction that you live in and the sort of political system that you're in.
I've got to say, I didn't know that prisoners weren't eligible for Medicare benefits. Nathan Gibson, did you have any thoughts about that? You're the Chief Psychiatrist of Western Australia. What are your feelings about the ineligibility of incarcerated people who have high-level healthcare needs in many instances, yet our public health system through Medicare is not always available to them in its fullest way?
Sure, and I think you can also include other groups such as asylum seekers who also, whilst there are contracted agencies that look after them and other religious agencies, they don't have the same access that others do. So there's a whole range of groups who are in the same boat, and even within the so-called middle class, you have a group who just fall through the cracks and don't get that same access or eligibility. An example might be for example, the adult ADHD group, controversial issue, but you get individuals who may be quite unwell very dysfunctional, heading into the criminal justice system, and they still can't get access through to public sector services. So it's not only those well-defined groups, I think, that we know about, but there are some other hidden groups there as well that fall between the cracks.
It's probably worth mentioning that in reality, most Indigenous communities outside metropolitan areas don't have access to Medicare services, to the fee-for-service medicine, and therefore rely on Aboriginal medical services and the public health system, basically because of where they are. So there is a very uneven distribution of services and funds that is, as I say, not closely related to need. And each of the groups that you've identified tonight are really the groups that miss out in some respect in terms of what's made available to them.
Marshall Watson, did you have any comment to make on the lack of access experienced by Indigenous communities?
Where do I start? Well, let's look at Medicare. Medicare, in its purest form, I guess, never really did suit Indigenous people.
In what way?
Well, in the way of, I guess, around issues of bulk billing, access to services, the need, and so forth. So we've moved to a model where a lot of Indigenous people, especially in rural remote areas, and even in Perth, like Aboriginal Medical Service, have Aboriginal community-controlled health organisations where a lot of the fee and a lot of the services provided through there as well. They're services that do the best they can, but they're also very much overstretched as well and under-resourced because the demand certainly exceeds the supply. And it's not so much about the number of people that come through the door, it's a complexity and burden of illness. The illness that not just affects the individual, but also affects the family and the family structure as well. So there's that added complexity to that as well. For those that, and you know, we've got 3% of the population that take a significant chunk of the healthcare system in the way of what they need. Indigenous people generally do present end stage or in crisis, and that generally puts pressure on your emergency departments and so forth and so on. Less than 3% of the population, 40% of our adult male population is Indigenous, and 80% of our juvenile population is Indigenous as well. So small population, huge burden of need, huge complexity of need, which puts a lot of pressure on the system as well.
Linda Morrison, you work at St Bartholomew's, which I believe is based in East Perth, and this is an organisation dedicated to working with homeless people who are among the most disadvantaged people in our society. Do you identify that the clientele that you're working with have a greater burden of mental health problems?
I think very much so. The program I look after, all of the residents in the program I look after are diagnosed with a mental illness. But we have another program, a housing program called the Independent Living Program. We've got a 4-year waiting list for that program. Our independent living units that we opened in Lime Street last year, we had twice the number of applications of units that we have there. Housing and affordable housing is a great issue, and the people who say who are marginalised, those who come as an asylum seeker, who come as an immigrant, who come to WA, end up at the bottom of the pile when it comes to homes. Apparently we're sort of about 200,000 homes short in Australia in general, and it's causing sort of houselessness as well as homelessness.
A 4-year waiting list.
That's for our program, yes. Yeah.
What do people do in the meantime?
Wait. You know, when it comes to other programs, there are any number of people who are sort of in hospital beds, which, you know, they don't need to be there. They could be out in the community if there was the affordable housing out there for them.
Presumably they're on the streets, many of them.
Some people are on the streets, yes, yeah. If you take the registry week last year, I think they identified probably about 180, 190 people actually sleeping rough just in the Perth city area that they looked at, in the area they looked at.
And when you're looking at those sorts of issues, people who are homeless and have, you know, those sorts of things going on for them, if you're worried about where your next meal is coming from or where you're going to sleep that night, then the idea of using any spare cash that you have to access, you know, to see a psychologist or to purchase medication is just alien.
Absolutely, and I think that's probably very relevant in particular for young people. And I get the sense that perhaps our traditional model of mental health care service provision doesn't really suit young people very well. Part of it's to do with cost, but part of it's a structural issue too. Do you have any comment about that, Annabelle?
Yeah, absolutely. I think that we have seen a massive shift, particularly in the last 5 years, to funding more early intervention and more youth-specific programs. For a long time it did feel as though we had children programs, which were people up to 18, and then adult was when you were over 18 and suddenly you were in an entirely new system, which was geared more towards people who were generally middle-aged. So not a very comfortable place to be for someone who has just turned 18 or is in their early 20s. And if you look at it from that purely, if you're looking at money and accessing mental health services purely from a mental health, from a practical point of view, and what you're entitled to under Centrelink, or if you're studying or trying to get a job and the wages that you're on. I mean, even if you qualify for a disability support pension and you're over 21, you're by yourself and that's for mental health, the maximum that you can get is $750 a fortnight. And when you take rent, bills, food, and when you look at how few people actually qualify for that maximum amount, there's no way that you can cover all of those necessities that you need day to day, and then I think it ends up being that mental health is seen as a luxury.
I think the thing is, we need to look at being realistic. Is our child and adolescent mental health services are stretched to the limit, and we're seeing a lot more kids come through those services with high prevalence disorders such as depression, anxiety and so forth. Now, if we take a step back, what happens to our marginalised youth and we're trying to access those services? And these are the youth that are coming out of custody, these are the kids that have been refugees or doing out-of-home care or whatever. We take a look at those that come out of custody or those that kids have been incarcerated, we have quite significant rates of complex post-traumatic stress disorder, comorbid conduct disorder and substance misuse. And we're seeing this in 15, 16-year-olds. Now, kids have just got to learn to be kids and teenagers and get through that 5 years. If you add on top of that those complexities, it makes it a lot harder. So we've certainly got much more need for our kids in custody and our kids that are marginalised as well, but I just don't think the services are actually able to, the mainstream services are able to, the child and adolescent mental health services are able to do it. And organisations such as Headspace, Youth Link, Youth Reach South are also getting a bit more stretched as well.
Nathan Gibson, I'm very interested to hear what you have to say in response to Annabette's closing remark, which is that mental health seems like a bit of a luxury. What are your views on that?
Look, I think it depends how you look at it. If you look at it from the perspective of developing countries where they have minimal amounts spent on mental health, we do quite well really in Australia. And I think we have to set that as a kind of a template. So I think we have to get that in perspective. But I think that's right. I think when you've got a choice between, and for some people it's a choice between food or cigarettes or whatever and mental health, and it's really it's really difficult to convince that mental health is the way to go. I mean, you have programs like the Street Doctor or the mental health outreach called MCOT, which provides mental health options through the Street Doctor, which has been quite successful in the inner city area. But they're programs I think which could be potentially expanded in the years to come to provide access when and where people are willing to access it, I think.
Can I just make a point? I mean, I think one of the problems in the way we think about mental illness amongst any group is that we tend to see it as residing in the individual exclusively. The way we talk about it and think about it, we talk about a person being mentally ill. But I think there's such a thing as toxic environments, that some circumstances that young people, Aboriginal people, asylum seekers find themselves in inevitably produce some of those consequences. And by putting funds, in a sense, into prevention, improving the environments in which people live, better housing, for example, reduced incarceration rates for Aboriginal people, structural changes, in other words, at the level of the society, reducing inequalities, these things will all produce improved outcomes. And I think by focusing always, as you must when someone's obviously at a traumatic point, but by exclusively focusing on that traumatic point, we lose sight of the fact that earlier intervention can make a huge difference to the rates of mental illness in our communities and the way we think about, if you like, all those stresses and strains that people go through normally in their lives, let alone the ones with complex health needs, as you've described, occurring in certain segments of the community. So I think some of the emphasis has been a bit misguided, well-meaning but misguided, and we should take a little step back sometimes and say, what is it about our society the way we treat our kids that's producing these elevated rates of anxiety or ADHD or whatever it is that people are seeking help for.
I guess then I'd like to come back to my original question then, which is if we're misdirecting our resources to the level of the individual, when in fact mental health problems can originate much further upstream, what can be done to address that inequality that perhaps leads in some way to mental health problems, but then also leads to lack of access to remedy that?
Well, the answer to that, I guess we could probably all make a fortune this evening. But I think part of the problem is that, as I say, the way we think about it, and then the way the resources are distributed. I was talking to a group of doctors here and other health professionals in the hospital this morning involved in pain management. Now, there are large elements of the experience of pain and pain management that are about mental health issues. And it's quite clear that if you think about it, the way we think about problems like sleeplessness, we almost always try to reside them in the individual. So that now we have shift work disorder. So we're going to treat shift work disorder. The truth is that people are not sleeping well, not eating well, developing anxiety, feeling bad about themselves, because their working lives are impossible. And to try and fix the individual and fit them more neatly into an impossible world is not actually a very smart thing to do. So I think sometimes there needs to be pushback. And I often thought that medical students and doctors, for example, work far too many hours and unreasonable demands were made on their time. And I've been waiting for the day when they say, enough is enough, we're not going to do that anymore. So that's just an example, I think, of where the situations in which people find themselves are inherently destructive, and you've got to ask that question.
On that note, this morning, the results of the Beyond Blue survey into the mental health of doctors and medical students was reported on. Medical students, which is most of you out there, 1 in 5 of you apparently will have experienced suicidal ideation in the past 12 months. And for those doctors of you in the audience, 1 in 10 of you will have experienced that. That's a pretty sad indictment on perhaps our medical culture, perhaps the demands that systems make on us. Perhaps it's an inherent part of medical education too. Sophie, what's your view on that?
I think what I'd like to see is some comparative data about other professions to see how it relates. In fact, if you look at community surveys, rates of depression and anxiety are actually quite high in the community, and so are rates of suicidal ideas. If you start asking people in surveys about suicidal ideas, you come out far more people have them than you would expect. So I'd be interested to see whether this rate is really elevated compared to other groups.
So
Because I to 1 in 40.
1 in 45
Yeah.
was the community rate. So,
Okay, well, then it is worrying. I think it's. I heard somebody very talking about it on the radio, saying that it's a mixture between the sort of demands placed on students and doctors and the overstretched services. The demands, I think something that isn't addressed much in training is how to cope with this person who was talking, I think he was from Beyond Blue, about how difficult it is hearing distressed people's stories all day long. And I think psychotherapists are very good about thinking about the effect that dealing with patients has on them, but I don't think that much time is spent on it. And particularly in other specialties, so oncologists, for example, are dealing with dying children and distressed families. So I think there are a lot of demands, and people, there is quite a lot of stigma, even amongst psychiatrists. People won't speak openly about mental health problems that they might have had, either for fear that they'll be reported to ARPRA or that they'll be seen as less professional. And it's very sad that people don't feel able to when they're trying to work against stigma for their patients.
I just want to pick up on something that you mentioned there about hearing distressed people's stories all day long. Marshall, you'd be aware more than many of us how much that within Indigenous families there is this sharing of sad story after sad story. Do you think this in part accounts for some of the really dreadful Indigenous mental health statistics? For example, the rates of suicide in Indigenous people is something like 4 times the national rate. Is that to do with this cultural and social milieu of sad stories and hearing them all the time?
I think the thing is, with Indigenous people, we have this collective existential despair. You know, without hanging over it in a sense. But also, you've got Indigenous people. They go to more funerals than most. They have a lot more traumas. They don't have a chance to recover from the trauma. They have a chance to recover from the grief, and it's this cycle building up. So it's another injury on top of injury. And then they have, you know, the issues with their own families to deal with and their kids in the socio-economic centre. So it does build up and up and up. I mean, there's a really interesting study. We look at Indigenous suicide as an example. Yeah, we do have higher rates of Indigenous suicide, unfortunately, and it's around issues, not just the individual, but it's around the issues of what's happening at the community level. We look at Balgo traditionally as a very strong community. The reason where things started to go wrong is where those markers of cultural continuity started to go. So where self-governance, traditional practice, land rights, all that started to erode, that's where rates of suicide increased. There was a very similar study done back in the late 1980s in suicide rates of Canadian First Nation youth, where it found that the lower the rates of cultural continuity, the higher rates of suicide. And I think we're seeing the same thing here for much broader issues that are not just focused on the individual, but at the community level as well.
Annabeth, I just want to bring you in here. You're a young person.
I am.
And traditionally, it has been young people who have sort of taken up the flag and grasped these social issues by the horns and been activists in drawing people's attention to these social issues. It seems to me that that kind of engagement is lacking in young people in this decade. What are your thoughts on that?
I think there's kind of 2 different answers to that. One, I'd say, I know through work that I do and, you know, with all you young people giving up your exciting Tuesday night to be here and other organisations, there are lots of young people in the community who are engaged in doing amazing things. I think one of the reasons why potentially we don't see them coming together as much is lots of community organisations can kind of work independently and there's less chance for them to come together as a community. I think the other flip side to that though is there's a general feeling that young people are disempowered and that we are not being heard and that our voices aren't important. And I think we're kind of told that, you know, politically we don't hold much sway. Lots of people under 25 aren't involved to vote, and I think, you know, it's kind of a chicken egg thing by saying there's no point doing it and then us feeling that we're not going to make any change actually by being involved. It's really important to try and bring young people back in, particularly when we're looking at things like mental health. Because when it comes to any sort of client work, then the consumer is the expert in their own experience. And they should really be at the centre. If you're talking about a whole team approach to improving mental health outcomes, then the person who's being treated is a member of that team. And they need to be brought into it. And that includes, you know, also their friends and their family and their community and those wider connections that they have. So it's about trying to connect the community back together and not keep everyone separate. So, you know, it's not just a doctor talking to a patient. It's a doctor talking to that person and looking at them holistically and looking at all of their different ties. And when we realise all these ties that we have, that's when we can actually build on those and make some changes.
Just to add on that, look, social media is a double-edged sword. You know, it's been really useful to get the message out there to youth, but it's also a really terrible way of bullying. The amount of cyberbullying that I've come across through social media through the stories I've heard is just horrific. So I think this is the other thing as well. And this is the thing is, yes, we do need to get the message out there and promote it, but I think when people are suffering, they're suffering in silence in their bedrooms online and where everyone can see it.
I want to come back to the issue of young people more specifically in a little while. I just wanted to pick up on something that you said, Annabeth, about organisations talking to each other. Now, Linda, you work for an organisation that probably, I imagine, works with a number of different agencies and has to work quite hard to integrate all of those services for the benefit of the consumer in the middle of all of those services. Do you have any comments on that?
Organisations working together, especially community managed organisations, It's sometimes a little bit sort of piecemeal. We quite often have sort of meetings that might be something like, let's say, which is the Eastern Region Mental Health Association, or partnerships that spring up between different community-managed organisations. And yes, we do all try to work as much as we can together and to integrate, but I still go to any number of meetings and I meet someone who's working for a small organisation and think, oh, I've never heard of them, and what exactly do you do? Because, we don't all know what every other organisation does. And, the more we can know, the better it will be, really, to make things work better and to help people get better outcomes, which is basically what we're all here to get. Is, to help our residents, our patients, clients, whatever particular person is called in the agent, to get a better outcome at the end.
And I suppose that's part of the role of community forums like these, isn't it? To just let people know about what is out there, what are the views out there, and who does what. And if you haven't already had a look at the stalls out the front, there are a number of very kind organisations who have donated their time and resources to be here. So in the interval, I'd encourage you all to go and have a look and have a chat with some of the people at those stalls. I just wanted to stay on the issue of Indigenous disadvantage for a moment. Carmen Lawrence, you've worked at the highest level of government, and I just want to know what your view is on the idea of an intervention that happens at the highest level of government, that is our Constitution. Do you think there's a role for the recognition of Indigenous people in the Constitution that will assist in some way to relieve some of the disempowerment, the displacement, the sense of dispossession that is really harmful to our Indigenous people?
I personally do, and talking to, more importantly, to Aboriginal and Torres Strait Islanders, it's pretty clear to me that they do too. I had a conversation with Tom Karma last week. We were talking about Indigenous ill health in Australia, and it was very clear that all of the participants in the group who were in Aboriginal and Torres Strait Islanders were very clear. They didn't think it was going to perform miracles, but that it was an important, a bit like the apology, an important recognition of the fact that Aboriginal and Torres Strait Islanders are the first people. This is, I stood corrected when I said it was the oldest living culture. Someone claims there's an African hunter-gatherer society that may be somewhat older. But, by these standards, this is an extraordinary culture that we have. And we don't respect it and we don't celebrate it. I'm also chair of the Australian Heritage Council, and this year we've decided to make Indigenous heritage the core of the work we do. We don't have a lot of resources to work with, but we know how important cultural recognition and respect is to Aboriginal people, especially because it's been so absent for so long. So I think that the strengths of Aboriginal communities reside in those strong connections with one another, the strong connection with land, many of which have been fragmented. So constitutional recognition, appropriate understanding of the history of disempowerment and disadvantage, and a proper respect for Aboriginal culture and language all contribute to better mental health outcomes, I'm sure, in the long term. We know, as you said, the West Australian work shows very clearly that those communities where children are still practicing language and culture are the most resilient. They're protected against some of those slings and arrows that we talked about that occur more frequently in many of these communities. So we should be trying to find out what are the things that actually assist, particularly young Aboriginal people, in bouncing back from some of the adverse events that otherwise can destroy their living.
It's a really difficult position that Indigenous people find themselves in. And I just want to, at this point, raise a really controversial case. In December last year, an Aboriginal man by the name of Tristan Dimer was mistakenly taken off the street, he was a homeless man, by police and taken to Greylands Hospital because he was believed wrongly to be an escaped patient from that facility. He was brought back to Greylands Hospital. He was administered involuntarily an antipsychotic, and it was only when he had an adverse reaction to that medication that anybody realised that something wrong had happened, and he landed up in the intensive care unit. Nathan Gibson You're the chief psychiatrist. Ultimately, your comment.
It's very interesting saying I was in charge of grants when this happened, so
Right.
raise that conflict we got there.
Okay. But perhaps you can answer a different aspect of this situation.
I thought we'll leave it, absolutely.
Certainly. Did you have any general comments to make?
Look, absolutely. And look, I was involved as chief psychiatrist in reviewing that retrospectively as well. There are a number of issues around culture of staff. There are a number of issues around procedures, tightness of procedures. Because, and this has been reported, I think, the classic Swiss cheese effect where you think, oh, something like this can never happen because there will be a barrier, and somehow it just moves between all barriers and reaches that. But certainly, I think this is the issue about the culture of staff, and also the complexity of dealing with an individual who, it's certainly been reported, is itinerant, is all of those things which staff struggle with to deal with. We work in a regional system where there are clinics that work for one particular region. If someone moves between a region, it then becomes more difficult to follow them. And I think where we struggle is to provide that continuity for those people who don't fit in the box.
I understand your comment about Swiss cheese, but I want to ask a really obvious question. Why didn't anyone recognise that he was a different person? And this comes to the question, and tying this back to the issues with Indigenous health and the treatment of Indigenous people within institutions. Do you think his cultural background played a role or in some way disadvantaged him and saw him fall through one of the deep holes in the cheese?
That's a really difficult question. I think the answer is that it probably was a contributing factor. How much of a contributing factor is one of those things that's up for debate. I think the issue is around he came from the person who had left Greylands came from one of the long-stay wards at Greylands, and so it is not just an issue of Aboriginality. I think it's an issue of the treatment of those individuals who are, if you like, long-stay patients within institutions, and how we manage them and how we treat them, and the need for it to shift towards a process where we can try and integrate them as best we can with the community.
Sophie, I want to bring you in here. You are a forensic psychiatrist at Greylands Hospital. Some people have suggested that this Tristan Dimer case is in fact the tip of the iceberg as far as mistaken identities are concerned. What do you think?
Well, I don't have to do my clinical work at Greylands Hospital. I do it in prison, and I haven't come across cases of mistaken identity that I'm aware of during my clinical career. But I do think that Nathan has a point about how do we deal with sort of people who are itinerant, maybe behaving rather oddly in public places, and what we do with them and how they're managed, and whether they're people who are part of a service that knows them well and is able to provide continuity of care.
There's a really tough question here, I think, for all health care providers, not just doctors, nurses, OTs, policymakers for that matter. There's some really interesting work out of Australia, but some indications in Australia that Indigenous people get poorer health care. Not because they live in remote areas, not because they are not privately insured, but because the relationship with the healthcare provider is more complex and compromised. There's in a sense, in all of us, a tendency, for instance, to downplay the significance of symptoms. Less likely to get treatment for cardiovascular disease, less likely to get treatment for cancer and mental illness, and that these results are repeated around the world, in the United States and the United Kingdom. If you're dealing with racial and ethnic minorities, the principal group of providers who tend to be from the dominant culture are less inclined, almost completely unconsciously, to provide the highest quality of care in dementia. And they're not aware that they're doing it. And it's a very difficult part of medical education, I think, to pull people up and to get them to think about that a little bit. Because, you know, even if you're just cutting the consultation a bit short and you're not looking in the eyes of the patient and you're more diffident even, it may not be overtly hostile, just diffident, you're saying something about your relationship, which is, I'm not very friendly toward you. And as a result, in those encounters, people are less likely to follow the advice they're given, less likely to take medication. We know that those sorts of encounters, you know, between people of the same race, if they're conducted in that way, produce poorer outcomes. And for a lot of Aboriginal people, I think that the medical encounter, the encounter with the health practitioner, the encounter with people working in our corrective services systems may well be fraught with an unstated discomfort at the very least, and maybe something more than that. Because in some cases it is something more than that. Let's use the word. Sometimes racism enters into those relationships.
There is the issue of racism, there's institutional racism. And in this case, you know, as an Aboriginal man sitting here, it saddens me that it happened. As a psychiatrist, an Indigenous psychiatrist, I know that the system is not perfect. I'm not making excuses for it, and it is a difficult situation. Indigenous people have, ever since colonisation, have been institutionalised and segregated. That plays out in the consultation. Unfortunately, it still happens on some level. It's why we struggle with Indigenous people in custody. It's why we struggle with Indigenous people in mental health, because the interaction with the justice system and the mental health system are very, you know, there's a huge power imbalance, and it just reverberates again. You know, it happens and unfortunately it does happen in the healthcare system.
Linda Morrison, do you think that the same sort of applies to homeless people as well? And I just want to paint a picture of a doctor sitting in his nice, clean surgery. It's a man, so we are staying with this stereotypical view of how the situation might play out. Male GP in his nice, clean surgery, and in comes a dishevelled man who's been staying on a park bench for the last few months. He is itinerant, he is unusual, he is malodorous. Do you think he receives the same level of care that Mrs. Granny Smith in Netherlands would had she entered that same surgery?
You'd like to think that he would. And I don't know, and I can't really speak from the medical profession there, but I think, you know, just from the point of view of looking at who is, you know, you say about the homeless itinerant person, but I mean, homeless people can be all sorts. It's not just the person, you know, the stereotype of the old man on the corner of the street. That's not what homelessness is all about now. I think when it comes to accessing allied services, the GP, other medical services, anybody who has perhaps a mental illness can find that more difficult. And I think, you know, the more integrated we can make the access into all of the services that are required, so that it's not just, okay, you can come here if you've got a mental illness, but oh no, you've got an alcohol problem, you're going to go here, and if you've got a physical problem, you've got to go here. You've got to look at the person as from a holistic point of view, because they all intertwine. They don't, you know, they're not separate things. You know. So you know, you would like to think that everybody would get the same.
Can I make a comment?
Perhaps from
I think the telling statistic is that, and this is work done by the Telephone Institute and published recently in the British Medical Journal, that you know, between 1985 and 2005 there was a worsening of the mortality gap for individuals with severe mental illness from physical health causes, not from suicide, but from physical health causes.
Particular programs to try to get a small service coordination for a particular person, so that all these dots are joined up to try to get the better outcomes. So, you know,
however, stick with this alternate reality of the asylum or the psychiatric hospital, and this hypothesis that perhaps when we closed the asylum, we ejected all of these people in need of an integrated care model that could be delivered in the one setting out where they were unsupported. Lawrence, did you have any theory about that?
I guess I watched, like some people in this audience who are a couple of my age, I watched that process, not only here but in other places, and what happened as the institutions were being closed or restricted in the number of people who would be admitted. The alternative wasn't provided. I think the story is very clear that they, in the end, those changes were cost-saving measures, and the community work wasn't done. And some people were extruded from institutions where they lived good portions of their lives, and so they were simply incapable of surviving in an environment without that support. So I think it's true to say that for at least the first 15, 20 years, as institutions closed down, community services weren't devised to respond to the needs of these people in the community, particularly those with serious mental illness. And to some extent that's still true, but it's not that the institutions themselves are extremely well funded either, but rather that public psychiatry has been underfunded for some time, I think, and that means that the work in the community is diminished. I was having a look today at the whole question of involuntary detention. I've always had, I guess, very grave reservations about the use of involuntary treatment of detention and the effects that that's likely to have in the long term. You get an argument, I know about that. But I was looking at the varying rates of involuntary detention around the world, and there are huge differences. Some countries use it quite freely, others not at all. And yet when you look at their mental health rates and treatment success, it's not related at all, as far as one can tell from looking at the OECD World Health Organization. So the fact that we use involuntary detention would appear not to have a lot to do with the long-term benefits to the people who are so detained. It may solve some short-term problems, but overall it doesn't seem to change the rates of benefits.
I think you can also see, particularly now, a shift towards more of that one-stop shop model that you're seeing. I don't think it needs to be someone who's admitted. I mean, for example, Headspace, which I will have full disclosure, that provides, for people 12 to 25, and it's all free, mental health, physical health, sexual health, drug and alcohol services, family and relationships, support for families with significant others, links to employment and education, and that's all provided in the one building. And we share it with Fremantle Medicare Locals, who's our lead agency, and they have Closing the Gap, Helping Minds, Partners in Recovery, Helping Living, so further counselling for people 16 and over, as well as dietitians. So it is possible to provide all of that, and once it is in that one location, it means that we can do things where once a week we have entire team meetings, as well as inviting all our outside consortium agencies, so another 8 specialist agencies in the community. And if you have those people who we keep talking about who have the multiple issues going on, then you can talk about them in that shared space and use the collective knowledge in the room to try and minimise the chances that they will fall through the gaps and make sure everyone who's involved knows the entire plan.
Then can I ask you, having said that, what is your view on the use of the Mental Health Act to detain people against their will to administer treatment?
Thank you for asking such a straightforward question. I think it's incredibly difficult to give any sort of clear-cut answer on that, and I think you can argue either way. I mean, obviously, some of the comments made before about how do we deal with those people who are acting in strange ways? How else do we respond to people who are at risk of harming themselves or harming someone else? I mean, if you're looking at it from, say, a family or carer's point of view, if they're concerned about a loved one, that might be the only thing they have that can get that loved one the support that they need. But then if you're looking at it from the individual, often, they've got all this trauma going on, and that whole experience is just trauma heaped on top. So basically, there's no clear answer to that.
We're going to wrap up this discussion because we've been going for nearly 45 minutes. But I just want to offer the last word to Nathan Gibson, who is Chief Psychiatrist and responsible for the execution of the Mental Health Act in line with its objectives. As you can hear, there is ambivalence out in the community, not just from people who work outside of mental health, but from people within mental health about the Mental Health Act and the way it is used. And there are vulnerable people, I think, who have found voices on this panel, the homeless, the Indigenous, young people. Are they vulnerable to the misuse of the Mental Health Act because they are not able to navigate the checks and balances that are in place to try and prevent this kind of thing happening?
It's a very good question. The current Act is, 100 and something pages long, and the new Act is probably going to be 400 pages long. But it is about the checks and balances and the automaticity of the checks and balances that occur. And I think, there are always varying forces that work together to produce a health act, and so it should be. I think that's part of an appropriate democratic process, and I think an appropriate community and clinical-based process. And I think what you end up with is, and what we will end up with, I think, is an act which has greater inherent checks and balances in it, which will. It's not perfect. We have to be quite clear, and will be a compliance cost on clinicians and the system to run the new act, but there will be greater inherent checks and balances with regard to shorter periods before there's an automatic mental health review tribunal hearing, the role of what they're calling nominated persons, so there will be always another person who knows you're in there and who's advocating for you. So these are all new things which are in the Act, and these are things which don't necessarily rely on an individual actually having the wherewithal or nous at the time to be able to action those. I think, like Annabeth, I just have to claim that I don't know the answer to that, and really I think that we have to make any piece of legislation work and translate it as humanely and as sensibly as we can.
Well, look, I'm sure we all look forward to seeing how some of these changes to the Mental Health Act play out. I'd like to thank all of the panellists for their contributions so far. We're going to take a short break, a 15-minute break, and I'd encourage you to return to the lecture theatre at about 8:15. In the meantime, please go outside. There is food, there is tea, there is coffee. Please speak to some of the people standing at the stalls. If you like, if the panellists make themselves available for discussion and you have a question that you'd like to ask, resist the temptation to ask it. Save it for the second half of our Q&A that will start back here in about 15 minutes. Thanks very much for your attention so far.